wrist and then we'll work up to the elbow. So obviously with the thumb, it's all about trying to find out what was the mechanism of injury, because that's going to seriously help you the way to strap it then to try and protect it. Thumb ligaments are very slow healers. Thumb conditions can go on for weeks to months. All it takes is a player catching in their pocket or catching a jersey and yanking it again and back to square one. So we tend to try and find out exactly what was the mechanism of injury. So obviously a lot of our ligaments either side of the thumb tend to be either the medial side collateral ligament or the ulnar lateral collateral ligament. And basically what happens is that normally it happens in extension, stroke, either abduction or abduction, where this ligament gets strained and this ligament. So the last thing you want to do is be strapping it into further stressing of the ligament. Okay, so you need to bring it back into that neutral position. So our assessment really is basically you're looking at glides, so you can do valgus and various stress tests on the ligament to see how lax the ligament is. You can do your mobilizations, so accessory glides to see what movements are occurring. Obviously you can do resistance as well. What do you think is the biggest area to watch out for in terms of a thumb injury, or what would be the main area around the thumb that you have to be careful of? Scaphoid, exactly. So where is the scaphoid located? Base of the snuff box. That's it. So get the person to look up, get the base of the snuff box and palpate it. So sometimes an injury whereby a ball can land straight down, forcing that jump straight down into the scaphoid can cause an issue with the scaphoid. The problem with the scaphoid, it won't show up for about 10 days after x-ray. 10 days after the injury. So it's no point in getting x-rayed within the 10-day period before that. So if you have a player that's still complaining of thumb, weeks in and past 10 days and still no better, obviously that's why, and he has pain in the base of the scaphoid, definitely that's something differential we need to rule out. Why is the scaphoid so important, or why? Blood supply to the scaphoid. So obviously if that blood supply was disrupted, it's going to cause necrosis of the scaphoid. And we've had a few guys in the clinic that then ended up getting a bone from their hip to make up their scaphoid. So you don't want that, So, and that's a guy complaining of on that the bone just died off, end of story. So necrosis of the bone can occur. So what we want to do is try and stabilize that joint as much as we can to allow those ligaments to heal. So normally we would use 1.5 inch in a clinic setting, or therapy we just buy 1.5 inch. You can have an inch strapping it. So the inch is easier and the smaller is the better one, but we tend to use the 1.5 inch. We just get lazy, so if this tape will tear, it's not very good. So we tend to just, this is how we use it. So we tear it to 1 inch positions. Okay, so what we'll do then is put the anchor on. Obviously if you're a guy with a big enough thumb like rugby, we tend to use the whole 1 inch or 1.5 inch. So you're going to hate this on the hair, but so just have your anchor, put it when it creases, and we'll do the 1 inch. So if we say the injury happened here, okay, so it end up being the ball end up pulling it and yanking out, so they end up straining the medial collateral ligament. So we're going to start in this position, come up around the thumb and the base of the thumb around, and we're going to pull it inwards to try and stabilize that position, that we're not overstretching it. Okay, back around again. Now some people will like to have it varies from player to player. You'll have some players that have quite a lot of soft tissue here. So what we might do is just get a little bit of underwrap, just as a protective mechanism. Yes, just a little bit of underwrap like that. And sometimes we might, before we tape, we might put it in around that position, just to stop friction of the tape and the tendon. But most players are fine. So if you just keep that neutral in there, want to come up and keep going up along the base of the thumb. So I'm trying to cross right on the aspect and then pulling it in towards. This tape doesn't tear very well and ends up called creases. That's my excuse and I'm sticking with it. Okay, so generally it depends on how bad the thumb is. You might do 3 or 4. Sometimes I might do this as well. If I really want to stabilize that joint, I might go all the way around to really stabilize that joint and then back down again if I need that. There's a whole lot of different ways of doing thumb tape, and then re-anchor it, finish it out. Other people might do, what they will do is have an anchor here and they'll do little strips. So they do 1 strip, 2 strips, just try and block that person from going into extension. And then other people might just do tape like that, individual tapes down as well to try and stabilize that thumb. This is probably the most simplest way of effective. You're pulling it in the direction. If you want to stabilize both sides, obviously then you're going to have to reverse it and go the opposite side as well. But because we said the Meckel's injury was here, he's only 1 pin on the medial collateral ligament. We want to protect that by putting in a kind of short, I wouldn't say short position, but neutral position. We don't want to be pulling it out further, so it's going to overstretch the ligament and delay the healing process. Different sports, same again. Gaelic football can play with the thumb out here, no problem at all. Hurlers need that little, so be careful of crossing this joint, because if I cross that joint and that stops you from flexing, then you're going to have a problem gripping a hurl. So you have to be conscious of how far you come up with the joint. Gaelic footballers, no problem, you're allowed to come up a lot of way because they just need to have the thumb out. Hurlers will need to have a bit of a grip, so you have to be conscious of that you don't come up too high in the joint to stop the grip strength. And that's basically it. So rule out the scaphoid, assess your accessory glides, palpate of course to find out is the main thing, and obviously just watch your circulation at the end, make sure it hasn't impeded any circulation. Is that? Okay.
What would be acceptable for the capillary refill on the nail, let's say?
Oh, instant.
Straight away.
That's it, you see it filling up straight away. That's it.
Can you put 100 up under there?
You can. But no, we don't.
Man up.
Sometimes what we might do, I use it because I just know up here, Carmen never use it. We tend to use tear-light stuff. There's tear-light stuff that is the exact same size as that, that's a lot bigger. But you can get tear-light exactly like that. And what you would do is use that then as your under wrap. So it's a nice way of and then you might only use 1 or 2 rolls of that then, 1 or 2 strips, because you're already getting support from this. So that's another alternative you can use. 1 inch, obviously of course, is a lot easier, and this stuff is a lot better. It's the mother stuff. 1 inch. If I was to do a knuckle then, or say a knuckle, player has say this knuckle's after being damaged. Same again, the roll that you've used, it always comes in handy, because these small ones then. So I might individually, rather than do buddy tape initially, I actually might just stabilise that joint individually. So I'll have an anchor below, and then I crisscross. So I'll come up like a diagonal, around, and then crisscross that joint. So I'm trying to stabilise that ligament, and vice versa on the other side if you need to stabilise it. You do a diagonal on that one. Just crisscross with it, and you can use up the part of the tape that you've already, either that you're using up that and you're not using it at all for anything. So we tend to use that for the fingers. Without creasing it or turning it. Okay. And then you can do your buddy tape then. So you'd individually, and then you'd have buddy tape below. And buddy tape above the joint. Just trying to stabilise that joint as best you can. So player has a problem with knuckle, that specific knuckle. Being to a hand therapist myself with this, it's a totally different way of treating hands, and it was an eye-opener to me to actually see the level of intricacy that they do with the hand in terms of exercises, in terms of splinting, that they would do, put splints on fingers, etc. So if you had a mallet finger, say you rupture that tendon, they would actually create a splint to try and keep that tendon, and then they would get you what we call activation exercises. A lot of these tendons they switch off very quickly, so the hand therapist has shown me in terms of you have to stabilize each joint. So what happens is that if I want to, say, make a fist with a finger problem, what you need to do is this joint can compensate for this one, and this one can compensate for that one. So what you have to do is actually spin the joint and only flex that top joint. So it's quite specialised in terms of you only want to move one joint, one tendon to try and get activating that tendon, because you do get lazy. Then stabilise the next joint and see can I flex the next one, and then stabilise and see can I flex the next one as well. So it's quite specific, the hand therapy. So if you ever get a chance to work with a hand therapist, brilliant. And then the way they have to put up TheraBands and make exercise with the bands and everything just to stabilise the fingers and get specific work. And you can get kind of a little gadgety things in certain clinics. Will have, say, like there's a ball here in the centre and there's 5 little kind of resistant bands come out, and you have to open up and close the ball and squeeze the ball. It's all about grip strength, trying to grip anything and get that strength back into the thumb. Isometric strength as well is quite important as well. So try and be able to stabilise that joint, push into it, stabilise, and get those muscles activated again, because they do switch off very quickly, and obviously that's going to restrict joint range of motion. So it's not all about joint mobs that I would have considered. It's actually that tendon, and try and get those tendon flexed again. Obviously it wasn't successful in that, and that's after one surgery. So basically what happened was that, what I found out after was that because the put pins in it, that pin actually caught the tendon, and that tendon now cannot flex. So the whole scar tissue was after. So the surgeon said, the hand therapist had said he'd have to go in, cut open that tendon, and it'd either put me in a fixed position in terms of that position, or that might be just enough to get that thumb work, that finger flexing again. But the fact that I could work with it, I just ended up not doing anything with it, because it felt better to have it rather than having a fused joint like that where you could get caught in it. I can work, and it's fine doing that. So that's called a swan deformity. So you will find these joints that was totally dislocated and fractured. So you'll find the hands can be quite problematic for some players. I think George Wexford, George O'Connor, if everyone sees his hands, you just realise how they're just, they're just all over the shop and crooked and dislocated and everything. Yeah. So that's basically fingers. Anyone plan to go to the States under placement? I won't do this